Within the last years, we see the trend of postponing pregnancy plans towards the third and fourth decennium, which comes hand in hand with the need of fertility consultation in couples older than 40 years of age. We have to be aware of the fact that in women after 35 years of age, we see the trends of diminishing ovarian reserve and reduction in oocyte quality. What we can investigate in those women is the hormonal profile, which gives us the information how the oocyte function is running. Another hormone that we investigate is called AMH, anti-Müllerian hormone, which gives us the information about the capacity of oocytes in the ovaries. We also know that the age is a higher predictive factor of the IVF outcome than the value of the AMH. As the ovarian quality lowers with age, we know that in older women we need to obtain more eggs in order to have healthy blastocysts suitable for embryo transfer. Roughly, in women in the age group between 35 and 37, we know that we need to obtain at least 5 oocytes in order to have 1 euploid blastocyst. In the age group of women from 41 to 42 years of age, we need at least 10 to 15 oocytes. And in women above 40 years of age, we need 20 and more oocytes. So what are the therapeutical options? The first one is the stimulated IVF cycle. In those patients, we have to be very precise in the evaluation of the predictive response to the ovarian stimulation. For that, we need both the hormonal profile, the MH, and very thorough ultrasound investigation of the small follicles on the ovaries. In women in fourth decennium, we usually need to go for high doses of stimulating drugs in order to obtain enough oocytes, or we can use so-called dual or double stimulation, which means 2 consecutive stimulations within 1 cycle. In women with diminishing ovarian reserve or in patients when the response to the stimulation is not adequate, we can opt for native IVF, which means that it's a cycle without hormonal stimulation. In the native IVF, we just do the oocyte pickup from the dominant follicle that has developed naturally within the menstrual cycle. Another option is to use the anonymous egg donor. The success rate of IVF decreases with age. This can be attributed to both the diminishing ovarian capacity or the lower oocyte quality. We know that the predicted success rate in women younger than 34 years of age is roughly around 40%. In women of 40 years of age and more, the success rate is no more than 17%. Another parameter that we evaluate in the IVF is the live birth rate. In women of 40 years of age, the live birth rate is around 12%. In the age group of 40 to 42 years of age, the live birth rate drops to 3.4%. Another option in the IVF is so-called pre-implantation diagnostics, which means that we are able to obtain the genetic information from the embryo prior embryo transfer. For this, we need enough embryos, which comes hand in hand with the good number of eggs obtained from the IVF. In women older than 43 years of age, roughly 5% of embryos are euploid, which means that they carry normal genetic information. The genetic testing of the embryos is only descriptive, which means that it cannot improve the quality of the embryos. It just provides us with the information and help us to pick the best embryo suitable for embryo transfer in order to increase the chances for pregnancy.